compliance as the walls of a ureter.
Yeah, that's a great point, and it's definitely something that we're considering, because to have that external pressure would be very helpful to see exactly how it's going to deform, right? It's not going to deform in this perfect shape, except maybe on the lab bench, right? And so I think whether we do that in this particular Abacus software, I think we could get it two-dimensionally pretty easily, and so I think that would be helpful, knowing some of the ureteral tissue parameters, and also something that we could, test in vitro, once we fabricate it too. But yeah, that's a good point.
Other questions?
Close the software to the real device. I mean, do you really expect that have you had any experience with this software before?
So this was my first time using the software, but they have shown using these parameters and this software that they were able to experimentally validate the deformation of this material, so the EcoFlex that we were using. So I'm eager to experimentally validate these results in the lab as things are relaxed, but at least in different form factors, they have been, it has been validated.
David Center, you had a question?
Yeah, I did. Do you predict, or do you think that inflation of the balloon will actually cause additional pain?
So in general, during the procedure, they're anesthetized. So it certainly is something to consider, especially when you're doing the operation. If there is some pain, it can lead to the patient moving while there's a ureteroscope in their ureter, which is not an ideal situation. So it may be that would be a good consideration to make sure that we're not causing significant pain that would result in the patient movement. But in general, the anesthetist, is carefully watching to make sure that the patient doesn't move during that part of the procedure.
And just to add to that, Dan, within the collecting system, there's no somatic fibers. So the only reason patients feel pain is through that distension of the renal capsule. So if you have an occlusion balloon and there was a lot of hydronephrosis proximal to that, yes, they could, be uncomfortable. The amount of distension that they have, for this short procedure is probably wouldn't add too much to the patient's discomfort under anesthesia, and most of them are paralyzed.
And in general, like the real advantage of these really elastic, very compliant materials is that you don't have to increase the pressure very much to get a significant deformation. And so because there's so much of that compliance, it's really going to form to whatever the geometry of the ureter is without applying too much force. So you'll be able to kind of occlude that, but if without exerting too much force on the delicate ureter.
How do you manufacture these small devices? Do you have a 3D printer for that, or?
No, so it's more like planar lithography. So
lithography.
Yeah, so photolithography. So similar to microfabrication techniques to make the computer chips. It's been extended to make different types of microfluidic devices and very precise geometries with very small materials. And silicone is a great material. It really conforms to whatever small features that you have. And so you basically use photolithography, which is, you have a silicon wafer, you have photoresist that cures with light. And so you can put whatever pattern you have on, you black out the parts that you want to dissolve, and the parts that are exposed to the UV light dissolve, and so you can make make very fine features on a mold, and then you pour the silicone in that mold and cure it. And so then you can layer the device. So you can, like, for instance, this is a 3-layer device that you would stack together.
And thanks very much. I think we should move on. This has been good discussion.
Oh, thank you very much.
Sorry, the timer was going off. Sorry.
Can we go back to Elliot, to Grace Ferry?
Hi, I still can't share my slides. Would you mind sharing for me? Thank you so much. Great, thank you. Hi everyone, my name is Grace Ferry and I'm a 3rd-year med student here at BU. My research over the past 3 years has been in the Department of Physiology and Biophysics under the direction of Dr. Atkinson and Dr. May. Next slide, please. Thank you. The project I'll be discussing today zooms in on the familiar concept of quote-unquote good cholesterol through the lens of a particular protein known as apolipoprotein A1 or ApoA1. Next slide. I know it won't come as a surprise to anyone when I say that diseases of lipid metabolism, namely cardiovascular atherosclerosis, remain the #1 cause of morbidity and mortality in Western society. But hypothetically, let's take a step back and let's say you exclusively eat bacon for 1 month. Now, I'm not making a judgment call, but I'd imagine you've got some cholesterol swimming around and clogging your arteries. There's got to be some mechanism that's allowing cholesterol to leave your system. And that mechanism happens to be known as reverse cholesterol transport. Next slide. I want to take this graphic of reverse cholesterol transport and break it down by introducing a few key players. Next slide, please. First, we have the transporter ABCA1, which shunts cholesterol out of peripheral cells in the body. Next slide, please. ApoA1 sees the free cholesterol shunted out of peripheral cells by ABCA1 and loops around it to form a double belt shape. This free cholesterol bound by ApoA1 is known as an early or pre-HDL particle, which we conventionally think of as our good cholesterol. Next slide, please. Once our pre-HDL particle is formed, ApoA1 activates and moves cholesterol to the next player of reverse cholesterol transport, LCAT, so that cholesterol can be in a form where it's able to leave your system. Next slide, please. What my research focuses on is the handoff between ApoA1 and LCAT. After cholesterol is transferred to LCAT, there's no going back. It can't diffuse back to the peripheral cells of your body. But the actual mechanism of how ApoA1 interacts with LCAT is unclear. Next slide, please. Previous work in Dr. Atkinson's lab has implicated 2 arginine residues on ApoA1 in this interaction between ApoA1 and LCAT. Our hypothesis is that the double belt ApoA1 protein shown here opens up in order to bind LCAT. Next slide, please. So I don't know about you, but this hypothetical opening of the double belt kind of reminds me of those claws in an arcade. However, this handoff remains purely hypothetical without a method of 3D visualization. And my method of choice is X-ray crystallography. Next slide, please. Here's a picture of me and Dr. Atkinson in the lab. We first designed a novel truncated protein construct of ApoA1, where the arginine residues implicated in binding to LCAT were central. Next, we expressed and purified the protein and grew crystals in the presence of a simple lipid, butyric acid, which we hoped would serve as a surrogate for the cholesterol transferred between ApoA1 and LCAT. Next slide, please. These are some of my crystals with the new truncated protein construct in the absence of butyric acid. Next slide, please. And these are some of my crystals with the new truncated protein construct in the presence of butyric acid. Next slide, please. I then solved the structure of the new protein construct in the absence of butyric acid. And here, as you can see, I've highlighted the potential binding site for LCAT in this magenta color. This new crystal structure is a development toward the structure of ApoA1 bound to butyric acid, but our work is still ongoing. Next slide, please. Designing this new protein construct brings us one step closer to figuring out how the conformation of ApoA1 changes in order to interact with LCAT. And understanding this interaction paves the path for drug discovery. Which residues are involved in cholesterol transport? What can we upregulate or inhibit to make this process of reverse cholesterol transport more efficient? Answering these questions will help us solve our fundamental overarching problem. How do we reduce the development of atherosclerotic plaques? Next slide, please. Thank you for listening to my talk, and I'm happy to take any questions.
Does this happen in a liver? I'm behind on this. So is cholesterol transferred out of, where does the transfer of cholesterol happens?
Mm-hmm. So ABCA1, that initial transporter, takes cholesterol out of cells in the liver and out of cells in the periphery. And that's kind of where it all begins.
Cells in the periphery, meaning what? Can you give me examples?
Vessel wall.
I'm sorry? Oh. I don't know if I can give you examples there. I need to check up on that.
Mm-hmm. And so the transfer occurs into the lumen of the blood vessels, right?
Mm-hmm.
And the actual ramping up of cholesterol occurs in the cells of the liver, right?
The pickup of cholesterol occurs from the cells in the liver, yes.
Right. And is the abundance of this protein defines the abundance of high density lipoprotein or high density particles in the blood?
Interestingly, no. It's not like you can increase the amount of ApoA1 or decrease the amount of ApoA1, and that's directly proportional with the amount of cholesterol in your body.
Do we know what defines the proportion of high density?
I don't think that we do right now. There have been a lot of studies where they've tried to completely delete it, and that ends up being horribly not beneficial, but it kind of depends on the population. So I think that's why we're focusing on this interaction.
Right, and the interaction again is between two subunits of this protein, right?
The interaction between ApoA1 and another completely different protein, lecithin, cholesterol, acyltransferase, LCAT.
I see. And do they have to first create a chemical bond before binding cholesterol, or they first bind cholesterol and then form chemical bond between each other?
ApoA1 first binds cholesterol, and then it binds LCAT.
I see. And then there is a covalent bond between these two different proteins.
Yes.
Is that so?
Yes, yes.
And is the covalent bond catalyzed by some enzyme, or does it occur spontaneously?
To my knowledge, there is no enzyme involved. The proteins themselves, ApoA1 catalyzes the interaction with LCAT.
Mm-hmm.
So,
Very interesting.
great. Thanks very much for that. Just perhaps a related question. You're using butyric acid as a model for lipid fatty acid. Why would you expect that to facilitate the opening up of the double belt? What is the butyric acid doing that opens up the belt?
In the simplest of terms, we were just trying to find the smallest possible hydrophobic particle that we could use to simulate exactly what a hydrophobic lipid like cholesterol would be doing in that situation. And those arginine residues that I highlighted in the very beginning from the structure that's already been solved from the lab, those arginine residues represent a hydrophobic core, if you will, where we expect the binding to take place.
Okay, thank you. Other questions?
Good. Are there any other questions?
Well, as a medical student, how do you find time to work in a lab?
This has been a project that's been going on for quite some time. I started my first year and now I'm in my third year. And luckily, I was a little bit familiar with X-ray crystallography. I worked with Karen Allen in undergrad. So I was kind of used to X-ray crystallography.
So there's a lot of synergy there. All right, good luck to you.
Thank you.
Thank you. Thank you. I mean, I'm sorry about the slides, but I'm glad it worked out.
No, thank you.
Good. All right, so poster number 31, is it Andre?
Yes.
Okay, perfect. So if you are all set, we can get started.
Do you guys see my screen?
Yes.
Very good. So I will talk, this study that I'm going to talk about has been published. So I'll quickly go over the study and then I will talk about greater implications of this. We have developed a novel intervention, novel language therapy for children with autism. And we have packaged this intervention into an application, enable this application in all the app stores, gave it for free to people. In return, parents had to complete evaluation of their children every 3 months. And we've got a lot of data. We've got over 1 million downloads over the 5 years. So it's a big study. In the end, we selected 6,000 and 6,500 children who have started with this intervention for at least at least 6 months, up to 3 years. And we compared this intervention exposed group to the children who did not engage with the application. And as you can see, the children who engaged with this intervention improved their receptive language significantly more than the control group. So this has been published, and FDA has granted this application a breakthrough device designation status. So maybe at some point we'll take it through FDA after the next randomized control study. Now, instead of talking about the study, I'd like to take you to the neuroscience of this concept, the prefrontal synthesis concept that we came up with about 20 years ago. And for that, you have to recall your recent dream. So recall your recent dream, the bizarre dream that you had in a dream. And notice that you can create the same bizarre images volitionally. So the dream is involuntary, and you create the same images volitionally. And it feels like different processes, and they are different processes. One is completely involuntary. In dreaming, the dream is created for you, and the other one is completely voluntary. On the neuroscientific level, dreaming imagination does not depend on the lateral prefrontal cortex. So this part of the brain is not involved in the process at all. Patients with damaged lateral prefrontal cortex don't notice any change in dreaming. And during sleep, this part of the brain is inactive. On the other hand, the voluntary imagination completely depends on the lateral prefrontal cortex. And if lateral prefrontal cortex is damaged, then in many cases, this is the end of the prefrontal synthesis. Interestingly, we call both phenomena imagination. In English language or in any language, there is no other way to differentiate. There is no way to differentiate between these two very different phenomena, and a lot of problems in both philosophy and neuroscience are arising because people don't appreciate the clear neuroscientific difference between these two mechanisms. So before we go any further, we are introducing this new word, prefrontal synthesis. So prefrontal synthesis is your ability to voluntarily juxtapose mental objects. If you imagine an apple on top of a whale, or trying to close your eyes and imagine how this sofa in the store will fit your living room, you are doing prefrontal synthesis, using your prefrontal cortex to synthesize images in your posterior cortex. Prefrontal synthesis is, of course, fundamental for fairy tales. When you read fairy tales, you read about things that you have to imagine voluntarily, and prefrontal synthesis is, of course, important for all the scientific models that we are learning in school. Everything from DNA structure to atom structure to quantum mechanics and so on. Prefrontal synthesis can be tested verbally. Let me test it on you. So then, if the tiger was eaten by the lion, who is still alive?
The lion.
Very good. If you watched your eyes for a second, you moved your eyes a little bit, and that's usually when people imagine that picture, the lion and the tiger together. Let's do another one. Grace, if the red cup is inside the blue cup, which cup is on the bottom?
Blue.
With lookup, yeah. Again, you saw that you have to imagine these two objects together. You have to manipulate them, and even though you feel that it is easy, this is not an easy task at all. Helia, the question is for you. If you take the number 77 and flip the first 7, and then bring these two figures together, what geometric figure do you get?
You're asking me? Oh,
Yeah.
Okay. I have no idea.
Well, just imagine it. You have 77, and you flip 1 7 horizontally.
I don't know.
Well, help us here. Anyone?
I'm the wrong person to ask. My brain doesn't work that way.
Is it
See, maybe I should be.
Triangle. Dan is very good at this. Triangle, of course, right? You have 2 7s, and you flip this one, and then you bring them together. It is a triangle. So you can test prefrontal synthesis verbally. You can test it non-verbally. This is an example of a non-verbal question from so-called non-verbal IQ tests. So these lines telling you the rule, and this line is asking the question. So what will happen if you combine this figure and this figure? Which one is correct? Just show me with your fingers. 1, 2, 3, 4, 5, 6. Yeah, number 5 is correct, right? Yeah, number 5 is correct. And if you combine this, and this, you're combining 4 figures in your cortex. Which one is correct? Yeah, number 4, this one. This is correct. So you all have prefrontal synthesis, of course, although this is a problem for for many people, especially children with autism. It is a known problem. Up to 40% of children with autism never acquire prefrontal synthesis. In the autism community calls this problem synchronous overselectivity or tunnel vision or lack of response to multiple cues, but basically this is the problem of integration. And so we created exercises for integration. The exercises based on both visual tasks, such as this. You have to match the shape, you have to match the color, you have to match the pattern, match the size. In a higher level, you have to match both the color and the shape, or the color and the size. And here you have to match both the color, size, and the shape. So the exercises become more and more difficult until they become very difficult, like this one. So these are examples of visual exercises. We also have verbal exercises. And here, for example, the child has to put the large dog behind the orange chair. So the child has to understand, has to integrate this picture inside his brain and pull this into this dog behind the orange chair. Or in here, the lion lives above the monkey and under the cow. So the child needs to arrange the animals in this house. So we created these adaptive exercises with many levels, very few words, but a lot of these visual spatial exercises. We gave these exercises, as I said, to children with autism, and we've got very good results. Now, I also wanted to mention how this prefrontal synthesis concept applies to human evolution. So as you know, humans split from chimpanzees 6 million years ago and were developing separately from the chimps. Now, the question is, when was language acquired? And by now, we're more or less confident that the speech was acquired about 1 million years ago. So Neanderthals were talking to each other. Our ancestors 1 million years ago were talking to each other. The question is when the full language was acquired. And to approach this question, we need to look at the prefrontal synthesis acquisition in our ancestors. And we can look at the following manifestations of the prefrontal synthesis: the representational art, the creativity, innovation, religious beliefs. And if you do that, then you notice very interesting things. So how old is this earliest artworks? What do you think? This is the oldest picture in the world. How old is it? Any guess works.
10,000?
Pardon?
200.
200,000. No, less than that.
12,000.
More than 12. That's date is worth remembering. This guy is 45,000 years of age picture. These guys are about 30 to 40,000 year old. This is 44,000 years of age. There is no art, no figurative art before 45,000. But once you get to 40,000, it increases exponentially everywhere in the world. In Indonesia, in France, this is from Dordogne region. In Germany, this is from Germany. And what we see, not only figurative art, but also the hybrid art. This is a clear proof of prefrontal synthesis ability in our ancestors by 40,000 years ago. So the number of these figurative art objects increases dramatically 40,000 years ago. What else is increasing? Well, we can judge religious beliefs based on adorned burials. And the number of adorned burials increases dramatically. Again, 40,000 years ago, this guy was buried with all kinds of bracelets and pendulums and so on. This is from 28,000 years ago. Another burial, and again, the number increases dramatically 40,000 years ago. If you look at the tools, how old do you think this oldest flute? Well, I'm sure you guessed, right? So again, 40,000 years ago, you see this explosion of all kinds of tools, and you see bow and arrow from probably about 60,000 years ago. So 60 to 40,000 years ago, humans really becoming modern, and we see all these manifestations of the prefrontal synthesis. What happens 65,000 years ago? Well, that's the last big wave of Homo sapiens out of Africa. Our ancestors, 65,000 years. Well, there were many waves out of Africa, but this one was huge. Our ancestors moved into Europe and Asia, and they apparently made boats to go to Australia. So it is still a mystery of why that is so fast. And one explanation that comes out of the prefrontal synthesis hypothesis is that it was a mutation that happened probably around 70,000 years ago. A mutation happened in at least two children. I call them Romulus and Remus. And by talking to each other, these children developed prefrontal synthesis in themselves. And that's how the full language came together. So the speech was acquired 1 million years ago, and then only 70,000 years ago did our ancestors acquire prefrontal synthesis, and that's when we have prefrontal synthesis ever since. So defining prefrontal synthesis enabled us to discover a very strong period for prefrontal synthesis acquisition. If you don't acquire it before the age of 5, it's a lifelong prefrontal synthesis paralysis. It enabled us to design exercises for children with autism. And it enabled us to hypothesize on the acquisition of the recursive language. I'm teaching 3 classes based on this, so if you're ever interested to order them, you have these. And all of this has been published, so if you guys are interested in this, you can look at the publications. Any questions, please?
Thank you, Andrei. This is really very interesting. And so we should probably all come and audit your course. There's actually a very interesting, recently published book called The Fossil Men that you might take a look at as well. It tells of the origin of man in Africa, pretty much. So questions, and because we really should move on to the last presentation, Dr. Quintiliani. Hearing none.
Well, I thank you for your attention, and I'll take a look at it. Thank you. Thank you, David.
I think you overwhelmed us all.
Yeah, I think you covered everything. All right, so with that, we're going to move on to poster number 11. Dr. Quintiliani, take it away. Oh, I'm going to stop screen sharing.
Hi, I just wanted to make sure everyone knew that Shanyin Yang is the first author of this publication. She's a graduate student trainee, and she'll be giving the presentation today.
Great, thank you.
All right. So hi everyone. My name is Shanyin. I will be presenting this poster about a narrative review for smoking cessation intervention for people with HIV in China. So first off, some backgrounds. Oops. Okay. So tobacco use is one of the most important preventable causes of premature death in the world. And in China, there are an estimated 316 million smokers, accounting for 27.7% of the entire population. Also, by the end of 2018, there is an estimated 1.25 million people living with HIV in China. So for this poster presentation, I refer to people living with HIV as PWH. And in China, there are 400 Chinese diagnosed as HIV positive every day. So comparing to the consumption of alcohol and drug, tobacco use has been shown to be associated with maximum severity of HIV-related symptoms. HIV and smoking can cause severe dysfunctions in the human body, such as lung cancer, cervical cancer, and stroke. At the same time, anti-retroviral therapy adherence and outcome among PWH who smoke are worse comparing to those who don't smoke. However, Chinese PWH have a higher rate of smoking than the general population. Chinese male PWH are shown to be 2 times more likely to smoke than the general male population. And Chinese female PWH have a significantly higher rate of using chewing tobacco than their counterparts. So the high rates of smoking among Chinese PWH is often due to distress that's experienced at many levels. And it's very different from the normal smokers in China. And also Chinese PWH experience higher degree of stigma, prejudice, and discrimination compared to their Western counterparts. HIV-related stigma is shown to be negatively related to high self-esteem and resilience, and is shown to be positively associated with smoking, other types of substance use behavior, and psychosocial distress, such as depression and anxiety. With the inactive stigma, it's the most harmful among all types of stigmas, which is the experienced stigma by the patients themselves. So mHealth is shown to be a great strategy for intervention to be widely distributed and implemented into the general population due to its readily accessible nature. And mHealth has been widely used for smoking cessation interventions in China. Interventions often include text messages that aim to improve self-efficacy and perceived social support. Taking one step further, when combining text messages with phone counseling, which incorporates motivational interviewing techniques, the cessation effect was shown to be more significant when comparing to text messages only interventions. And in China, WeChat has been a prominent communication mobile application, sometimes replacing text messages and phone calls. WeChat interventions has also been shown to improve medication adherence and quality of life for PWH. So our goal of the study, we want to have a better understanding of the special needs and motivations for Chinese PWH to quit smoking. We also want to evaluate existing smoking cessation interventions for Chinese PWH. At the same time, we want to examine what would be the best form of intervention to be generalized into the larger population. So a narrative literature review was conducted of the strategies and interventions for smoking cessation among PWH in China, with a special focus on technology-assisted interventions due to their scalability potential. And as shown on the graph, the review process was conducted through searching keywords in China CNKI database and Google Scholar in both English and Chinese. So as a result, we examined 21 descriptive studies, report, and governmental documents. Chinese PWH who smoke were shown to have a higher interest and are more likely to have tried in-person or technology-based behavioral smoking cessation interventions, comparing to those without a positive HIV diagnosis, with the percentage being 55.9% versus 42.9%. It was shown that perceived and actual social support facilitated cessation, while the internalized HIV stigma and psychological distress hindered cessation effort. Furthermore, we looked at 25 intervention studies, smoking cessation intervention in particular in China, and almost half of these 25 intervention studies incorporated technology-assisted approach and showed higher quit rates for intervention group comparing to the control group. Interventions contain telephone counseling, text messages, and mobile notifications. Some effective theoretical constructs that are often used are self-efficacy, perceived social support, modeling, outcome expectations, and behavioral capability of quitting. However, we didn't find any technology-assisted smoking cessation interventions specifically targeting the needs of PWH in China. So from the literature review that was conducted, it's shown that there's a need for technology-assisted smoking cessation intervention for Chinese PWH. We found that promoting social support and decreasing HIV stigma through these platforms can be a promising strategy. Despite the extensive effort on HIV medication and treatment among Chinese population, there's a lack of research identifying the risk factors and needs that are specific for PWH smokers. Healthcare providers who see Chinese PWH regularly in HIV clinics are not aware of the benefits of smoking cessation outcomes on their patients. So counseling for smoking cessation is placed at a lower priority comparing to regular HIV treatments. As a result, although Chinese PWH have high interest in quitting, they don't have access to appropriate resources. Due to the gap in literature, rigorous qualitative studies needed to inform culturally appropriate cessation interventions using technology-assisted platforms so that these interventions can be generalized to the greater population. And based on our result, we are conducting qualitative interviews and small group discussions among men and women, current and former smokers. And the interviews and discussions are currently taking place in the 4th People's Hospital of Nanning in Guangxi province. And Nanning city is located in the southern part of China near the Vietnamese border with a population of about 7 million people, which is nearly 10 times the population of Boston. 4th People's Hospital is the only hospital in Nanning city that mainly serves patients with infectious disease. The qualitative interviews focus on obtaining participants' opinions to inform the development of the smoking cessation program, which will include mHealth, behavioral counseling, and NRT. The mHealth component will be delivered through text messages or WeChat messages. Currently, 3 qualitative results has been collected and transcribed. These preliminary results show that quit rates were frequent, or quit attempts were frequent but not successful. Social support is a big factor that will hinder or facilitate their cessation effort. Messages that link HIV treatment to cessation outcome was thought to be helpful with cessation. Participants hope the counseling sessions to be scheduled at a time and location that's convenient for them to attend, and they will continue to attend in the long run if they think that the interventions are useful. So in the later phase of this study, a pilot trial will test the interventions' feasibility and preliminary efficacy. If effective, this intervention will have a high potential to be delivered to the larger PWH population in China. And thank you for listening. We'll take any questions.
Thank you, great presentation. Is smoking in general declining in China or growing?
I think it's been slowly replacing with e-cigarettes, especially in the younger generations. But in the middle age and older population is still there. They're still smoking at a really high rate. Yeah.
So there was no program like in this country where everybody really came together to stop smoking at the same time.
A lot of them are, I think most smokers are aware of the harmful effect, but many of the times smoking is a way of socializing in China, especially in business locations. Oftentimes, when somebody hands you a cigarette, you have to take it in order to have more conversations about your business or appointment or whatever. So I think that also plays a pretty major role.
Thank you, Xianying. This was really impressive. I have a quick question regarding your prospective study. How will you assess the efficacy? Will you have a control group, or will this be a pragmatic trial to test the benefits of the e-communication with the patients, with the smokers?
Yeah, so we'll have a control group and the intervention group, and to see if this will work out. Yeah.
Are traditional smoking cessation programs more successful or less successful in China than they are, for example, in the United States?
That's a good question. I actually haven't compared between the countries, but I know in different countries, these kind of interventions, they would tailor these interventions and the content to the culture. I know they have like an intervention in India where they like had the same text bank, a text messages bank that they kind of tested out in the US, and they moved it to India, and they modified many of the elements and they applied it there. And they also did the same thing to Chinese population. But I'm not aware of like the comparison between the results between these countries, but I know they do borrow from each other and then they modify the content.
Great. Any other questions? All right. Well, that concludes our the CTSI's poster session. I hope everybody learned something new, and thank you for attending.
Thanks much, everyone.
Thanks, everyone.